Central nervous system tumors are the leading cause of death in children with cancer. Cerebellar astrocytomas account for approximately 15 to 25% of these, with a mean age at diagnosis of 7 years. In general, there is an equal male to female distribution. Typically, children have vague symptoms such as morning headaches and projectile vomiting for several months before an actual diagnosis is made. Headaches occur in the vast majority, up to 84%, vomiting in 74%, and macrocephaly in 14% of cases in the young. Visual deficits and coma occur more infrequently. The majority have papilledema. In the cerebellum, the most common childhood tumor is the WHO grade 1 pilocytic astrocytoma. This is histologically a pilocytic astrocytoma demonstrating a biphasic pattern of dense fibrillary and microcystic tissue architecture. Common to this disease are eosinophilic granular bodies, in addition to Rosenthal fibers, which are also seen in craniopharyngiomas and Alexander's disease. Malignant transformation of cerebellar pilocytic astrocytomas are a rare result of a second hit phenomena such as inactivation of the p16 tumor suppressor gene. BRAF V600E fusion rearrangement is more common in cerebellar astrocytomas and carries an improved 5-year survival rate. Cerebellar astrocytomas have a low recurrence rate, and gross total resection can be curative. The incidence of dissemination of low-grade astrocytomas outside the brain is approximately 4%, and even though this risk is low, MRI of the brain and entire spine before surgery are warranted. Imaging characteristics of astrocytomas in the cerebellum include T1 hypointensity, T2 hyperintensity, similar to that of CSF. There's often a solid mural nodule that can appear hypointense in comparison with nearby brain parenchyma on T1 weighted image. These lesions do not typically generate a large amount of vasogenic edema. There are varying degrees of contrast enhancement, both of the mural nodule as well as the accompanying cyst wall structures. Detailed discussions with anesthesia regarding surgical goals prior to the patient entering the operating room are critical. Some of the key topics to discuss are the need for prone positioning, the need for significant neck flexion, the possibility of high volume blood loss or air embolism, and the need to modify anesthetic parameters to allow continuous intraoperative neuromonitoring during surgical resection. One feared complication of posterior fossa tumors, including cerebellar astrocytomas, is cerebellar mutism, or posterior fossa syndrome, which occurs in 11 to 29% of patients undergoing surgery for posterior fossa tumors. It is defined by ataxia, hypotonia, cranial nerve palsies, hemiparesis, and emotional lability. It is further characterized by a delayed onset, approximately 24 to 144 hours after awakening from anesthesia, a duration of 4 months or less, and recovery of speech that is most commonly associated with a moderate to significant amount of dysarthria. The symptoms of cerebellar mutism may be secondary to damage to the dento-thalamocortical pathway. Postoperative surveillance imaging and multidisciplinary team follow-up are warranted even in those patients who have undergone gross total resection. Nearly all pediatric low-grade gliomas have alterations in the RAS-MAP kinase pathway. This can be due to a loss of neurofibromin 1. In non-neurofibromin 1 associated low-grade gliomas, the most common alteration is the fusion of the BRAF and KIAA1549 proteins. This leads to a deletion of the regulatory domain of BRAF and constituently active BRAF, which activates the RAF-MEK-ERK pathway, leading to cell proliferation. There are also smaller numbers of the BRAF V600E mutation. Others have mutations in the fibroblast growth factor receptor, which leads to activation of the MAP kinase pathway and mTOR pathways additionally. More aggressive low-grade gliomas have silencing of the P16 INK4 alpha locus. This bypasses the anti-tumor mechanism, leading to continued cell cycling. Cerebellar astrocytomas can be well circumscribed, as in panel A with a mural nodule in the cerebellar hemisphere. They can also be within the brainstem and also have a solid appearance on MRI imaging, as in panel C. Figure 3 demonstrates a cystic type cerebellar astrocytoma. Starting with panel A, there's a CT scan demonstrating obstructive hydrocephalus from mass effect on the fourth ventricle. This tumor's appearance on MRI was cystic with an enhancing mural nodule as well as a partially enhancing cyst wall, seen in both panels B and C. In panel D, we are demonstrating the post-op initial scan and a sagittal view, in the same in panel E on an axial view. And then in panel F, we're demonstrating long-term follow-up at 7 years, demonstrating no evidence of tumor regrowth. In figure 4, we're demonstrating diffusion tensor tractography for preoperative planning. In panel A axial T1 post-contrast image demonstrates a right cerebellar hemispheric tumor. This is demonstrated also on the T2 imaging in panel B. Panel C demonstrates the superimposed white matter fiber tracts from the superior cerebellar peduncles, which course medially to the tumor. This is also seen in panel D, where we're showing the superimposed superior cerebellar peduncle fibers tracking superior to the tumor. Diffusion tensor tractography can be very helpful for preoperative planning as well as intraoperative mapping of tumor anatomy.